May I invite the next speaker, Dr. Sucheta Saha, consultant psychiatrist at INK, for her talk, please.
Good evening, everyone. I understand 4:15 is the perfect tea time, but still I would request everyone for their kind attention. My topic of discussion is rehabilitation in palliative care. So, we have already come towards the end of this conference. At this moment, I don't think I need to reiterate the definition of rehabilitation and what is physiatry and who are physiatrists. So, what is palliative care? That has been dealt with by my previous speaker very nicely. I will focus more on the rehabilitation strategies in palliative care. So, why do we need rehabilitation in a case of palliative care? Because integrated care can give a better outcome. So we should have a patient-centered, goal-oriented program for maintaining and promoting functional independence and to prevent, slow down or reverse the complications of physical deconditioning. Even at the end of life care, rehabilitation does have a role in, we can advise the relatives, the caregivers to maintain proper posture and positioning of the bedridden patients, to maintain skin integrity, to prevent bed sores. Pain control is at most important even at the end of life. Bladder and bowel care should be advised to the caregivers, and prevention of fall of injuries is very important. Rehabilitation team has been emphasized previously by my previous speakers, and again I'll give emphasis that rehabilitation is a team game. We have our physiotherapists, occupational therapists, speech language pathologists, orthotists, prosthetists, rehab psychologists, rehab nurse, rehab health assistant, vocational counselor, social worker, and our nutritionist in our team to make it a comprehensive care. Together we act to improve the functionality of the patient. As we can see in this slide that occupational therapists help the patient by use of different kind of assistive devices. Physiotherapists mainly take care of the muscle strengthening and endurance part. They also give gait training to the patients in challenging surfaces with walking aids. Occupational therapists also advise the patient regarding fall prevention and home modifications. Our prosthetists and orthotists give some replacement of the missing limb, that is called this. Here in this picture we can see the BK prosthesis and the foot prosthesis that can be very useful in cancer patient who has lost their limb due to surgery, due to malignancy, etc. So here we can see the role of orthosis, how a deformed limb can be put into shape, and we can prevent contracture with the use of orthosis. So what I need to emphasize that oncological care is not only the concept of rehabilitation in palliative care. We must also include other chronic illnesses. Like in our institution, we are treating patients with chronic neurological disorders like motor neuron disease, Parkinsonism, stroke, Guillain-Barré syndrome, traumatic brain injury, spinal cord injury. They also need rehabilitation and palliative care both, along with cancer rehabilitation, which is a vast topic. In cancer rehabilitation, we mostly deal with cancer-related pain, cancer-related fatigue, bony metastatic disease, radiation-induced tissue damage, lymphedema management, and nutrition. So in cancer-related pain, WHO says that 25% of the patients die with unrelieved pain. It can be due to direct tumor invasion or post-procedural pain, or can be a peripheral neuropathy due to chemotherapy induced tissue damage. So we treat the patients with WHO pain ladder, and of course interventions are also required for cancer pain management. Cancer-related fatigue we'll discuss in detail if I get time. Fatigue is very important and has been discussed earlier by our previous speakers. Bony metastatic disease can cause skeletal instability. So from the physiatric part, we do stabilize the spine with spinal braces, and sometimes we need to intervene by surgical methods, by spinal fixation. Radiation-induced tissue damage, it can be mucositis or can be skin damage that has to be taken care of. Lymphedema management, Mostly we deal it in two phases. One is the decongestive phase, another is the maintenance phase. In the decongestive phase, the phase 1, we do manual lymphatic drainage, and we advise the patient to use compression stockings. In the maintenance phase, we teach the patient how to do self-exercises and use of compression garments. Nutrition is utmost important, because we know malnutrition can lead to poor participation in the rehab and as well as poor recovery of the patient. So in our institution, when we treat the patients for rehabilitation, neurorehabilitation especially, we start in the inpatient. As our previous speakers have emphasized that rehabilitation should be started as early as possible. So for improving the functional status, we start the rehab even in the ITU and HTU. And in this period of inpatient rehabilitation, we try to get caregiver training so that the management of the patient at home can be easier for them. And geriatric rehab is also a part of our inpatient rehabilitation. After the inpatient rehabilitation, we prepare the patient and the caregivers for home rehabilitation with a maintenance program so that the patient can maintain his self-care, transfers, household ambulation, stair climbing by himself, and community integration is our goal of rehab in the long term. So here you can see that we start our mobilizing the patient even in our I2 and H2. Vertical orientation is being done with the tilt table. Here you can see that a stroke patient is being given gait training with long knee brace, AFO, and quadruple cane. Here we have a patient who is a post-operative case of spinal tumor. So she became paraplegic after the surgery, and there was absolutely zero power in her lower limbs, and later on she developed spasticity. So we cannot cure this disease, and she responded very well with rehabilitation. We can see that she is walking with bilateral knee ankle foot orthosis and a reciprocal walker. So definitely she will be in need of palliative care along with the treatment of rehabilitation. So here comes a body weight supported treadmill training, a body weight supported gait trainer, which we call the Maximove. With this, we can train the patients even with very low power, even less than anti-gravity power in their lower limbs. So this is a standing wheelchair. Another paraplegic patient whom you can see that he's smiling after many months because he was able to stand, and he can be able to talk to you with his eyes on your eye level. So that was a great psychological benefit for him. And this patient, again, a polytrauma patient treated with below knee processes, and this patient we started from comatose stage, and later on he started ambulating after proper neurorehabilitation. So we are emphasizing on exercise, but how does it help? Physical activity has shown to be protective against the development of some cancers, most notably CA breast and colon. Cancer prevention recommendation developed by American Cancer Society include at least 30 minutes of moderately vigorous physical activity on 5 or more days of the week for adults, and at least 60 minutes for children and adolescents. Exercise studies performed in cancer patients has shown substantial gains in cardiopulmonary fitness, fatigue, quality of life, depression, anxiety, and it improves immune function. But safe exercise intensity must be identified in every palliative care patient, because each and every patient is different. There is no single one-size-fits-all for these patients. An optimal rehabilitation program may include aerobic exercises, flexibility training, resistance or strengthening exercises, and a graded reconditioning program may be helpful. But we should take precaution in cases of thrombocytopenia. If the platelet count is less than 50%, we can do all kind of therapy, but when the platelet count is 10,000 to 20,000, we must restrict the strengthening exercises, weight bearing exercises. And then if the platelet count is less than 10,000, we should stop. Only active exercises are allowed. The strengthening exercises should be restricted. In case of thrombocytopenia, if isometric exercises are allowed, that may give rise to the rise in BP, and that may cause
Just over 3 minutes.
intracerebral hemorrhage. In case of deep vein thrombosis and bony metastasis, spinal instability, first we must stabilize the spine and then we should proceed for rehabilitation. Home care is very much important. These are the pictures from my palliative care fellowship. So we went for home care in these patients. Geriatric care, we follow preventive strategies, restorative strategies, supportive strategies, and rehabilitative strategies. We give them home exercise program so that they can maintain active aging. Polypharmacy should be avoided, as we all know that polypharmacy can cause a lot of side effects in those patients. Integrated and coordinated care between the primary care physician, the rehabilitation physician, and the palliative care physician is at most important. Primary focus should be on minimizing symptom, restoring function, coping with disability, and decreasing the burden of chronic disease. Home is the best place to take care of the elderly, as we all know. Institutional care should be reserved only for acute illness. Support of the caregivers is essential, and understanding the values and beliefs of the individual to plan for future care should be taken care of, because the individual may refuse terminal treatment in ICU, so we must value that. Geriatric rehabilitation, we focus on 3 F's: fall prevention, frailty prevention, and fatigue. So I don't think I have much time left. So fall can be very devastating for a geriatric patient. So fall prevention methods, as we have already seen, we should follow that and advise the patients and relatives. Frailty, how can we diagnose that? 3 among these 5 criteria mentioned over here. And frailty, if diagnosed very early, we can reverse it to a non-frail state. Fatigue is an unusual, persistent, subjective sense of tiredness that interferes with usual functioning, and we can manage it with energy conservation techniques, some exercises, stimulant medications, steroid medications, and psychological therapies. Here we can see that recreational activity can also help in maintaining the psychological well-being of our patients. In our ward, we routinely practice that. Caregiver support also needs a team of doctors, nurses, psychologists, and social worker. Here we emphasize on the prognosis of the patient and regarding future care plan with the caregivers. Cancer rehabilitation, as we all know, breast cancer post-surgical pain is very important. We must take care through the WHO pain radar, and we also use some modalities like transcutaneous electrical nerve stimulation. Regional shoulder dysfunction is very common after breast cancer surgery. Cancer pain syndrome, as we can see in this picture. Lymphedema management, I have already described in short. Psychological adjustment needs should be taken care of, and breast prosthesis should be provided for social integration of the patient. Head and neck cancer, swallowing dysfunction can be taken care with swallow therapy. Radiation-induced mucositis and xerostomia can be helped with local agents. Impaired communication, dysarthria, dysphonia, aphonia may be there. So speech and language therapy can help the patient to a great extent. Sometimes when the surgical resection is there, electrolytics may be used, or some augmentative communicative devices can be used. Pain control is a must. Soft tissue contracture can be helped by stretching exercises. In lung cancer, pulmonary rehabilitation has a great role. Hematological malignancies, as we have already discussed in thrombocytopenia, active exercises should be encouraged, but restricted bony impact is advised in case there is extensive bony infiltration. Bone and soft tissue cancers, amputation can be helped by prosthesis. Limb sparing surgeries can be given orthosis. Remobilization exercises are helpful in every cases. The most important thing is the care of residual limb. That should be advised to the patient. Compression dressing to control edema, promoting wound healing, and maintaining alignment is very much necessary. Giving the prosthesis itself is not sufficient. Prosthetic grade training should be given to accustom the patient with the new processes and psychological counseling for acceptance of the disability of this patient. My junior, Dr. Roktim Shornokar, has given a very good paper write-up on integration of rehabilitation and palliative care in cancer management, which is a must-read for all the physiatrists. To conclude, a combination of rehabilitation and palliative care can improve the quality of life of a patient to a great extent. Both palliative care and rehabilitation needs remain unmet for many patients. Integration of rehabilitation and palliative care in the disease-specific care of the patient is utmost important. An interdisciplinary team can overcome these challenges. And here is our healing team at INK. Thank you.
Thank you both. Now the topics are open for discussion. If the House has any question, we can take those questions, one or two. No, if there are none, then I declare the session closed. Thank you all for the patient hearing.